I think one way of splitting up the number of biomarkers in lung is to think about them in terms of ones that are appropriate for non-small cell lung carcinoma and ones that are in neuroendocrine tumours. And in the context of non-small cell lung carcinoma, we can really think of those as ones that are about the tumour cells specifically and inherent properties about those. So that's why I'm thinking about EGFR, our ALKs, our single driver mutations. And then on the other side, we have things like PD-L1, which is a biomarker which is more involved because it requires interaction of a tumour cell and its microenvironment. And that interaction between the two is what really makes it key for understanding its predictive power. So if I talk about PD-L1 programmed deaf ligand for a moment now, one of the challenges with this is that its accuracy, its predictive power is not as great as we would like, and it's got a confusing status as complementary or companion diagnostic depending on indication. Because of this, we often find that there is difficulty questions on the practical implementation of this and how we can best modify it and get the most out of this data. And as I say, this is because we need other biomarkers to be looking at in the context of that microenvironment for really to be really important. Some of my work that I've looked at has compared different specimens and different modalities of sampling different tumours because there's a big element of confusion over what samples are the most appropriate for PD-L1. And what I found is that there's a lot of variation between a primary lung tumour and metastases to regional lymph nodes. As many as perhaps half of cases might have some form of discrepancy. And in terms of changing the clinical guidelines of where that threshold would fall for determining treatment, that may be as many as a quarter. So it's a big issue when it comes to sampling. But when we look at the metastatic deposits from each other, we see the same sorts of patterns of variation, but to a lesser degree in terms of frequency. So these may be more representative of a patient's total tumour load, but I think we always have to accept that any one specimen, particularly of PD-L1, a single biomarker is just going to give you an element of error which will make it tricky. So in the context of non-small cell lung carcinoma, one of the big ones is tumour mutational burden. So TMB is a biomarker that essentially looks at the neoantigenicity of a tumour. Now it's a surrogate marker for that, but the implication is that neoantigenicity is at least in part an indicator of how much of an immune response it may generate. And the difficulties around TMB are that there's no clear consensus on how we would even define it, and there's no clear consensus on how we would even test for it. If you look at any of the big panels, the Illumina panels or sequences that are looking at TMB, they require considerable amounts of tissue. And very often we're dealing with small diagnostic specimens that just aren't going to provide us with this level of tissue. Another interesting point is, if we are looking at an NGS-based panel of specific driver mutations for lung, and maybe that's 20 drivers or so, and we think that that would be enough tissue to give us TMB, it may well turn out not to be. But even if it was, the regions of the genome we're going to be looking at are inherently different to what we would be doing if we were looking at a different panel. So the question of how to deliver tumour mutational burden is a really pressing one. Saying that, what evidence there is on it is that alone, it's a very powerful predictive biomarker, but particularly combined with PD-L1 status, this seems to show fantastic predictive power for patients. So it's something that's definitely we need to continue to look at.